Good morning, the Sarah Department of Medicaid. Can everybody hear me okay?
Yes, Aaron.
Yes.
Oh,
Yeah.
okay. All righty. Our waiting room is cleared, and I
Hey,
believe I counted 4 TAC members. Did I?
Yeah, here.
that is correct.
Okay. All right. I'll turn it over to you guys.
Good morning, everyone. My name is Stephanie Moore. Patrick wasn't able to attend the meeting today, so I'm going to step in and chair today's meeting. So Sarah, I believe we've already established quorum. Is that correct?
Yes, ma'am.
Okay. All right. So we will move on to approval of minutes from the previous meeting.
This is Michael. I'll make a motion.
Thank you, Michael. Is there a second?
This is Barry. I'll second.
Thanks, Barry. All in favor, aye.
Aye.
Any opposed? All right, so moving on to old business, an update on THE wind down redetermination. Is there someone from the department who's going to provide that update today?
Hi, good morning. This is Veronica Judy Cecil, Senior Deputy Commissioner. Nice to see you all this morning. I am gonna, let's see, Aaron, can you make me a co-host?
Already done.
Oh yeah, you're so on top of things. Thank you. I always just like to show a couple of screens because I think it's just sort of easier to see the information that way. But I'll be very quick. We do not have yet, as of course, at the end of every month is when we perform the kind of final update for redetermination for that month's renewals. I don't have November yet. So what I do have to share is September was our last one. So looking at September, we had a very large number of beneficiaries that were subject to renewal. And the reason for that is just to remind folks that we were implementing continuous coverage for children. What that is we would, if we determined a child eligible upon redetermination, then we would automatically give that child continuous coverage for 12 months. So if there was a change in income or change in circumstances, we would not process that, and that child would remain covered for that full 12 months. It gives, there's a lot of churn with children eligibility because the child income is higher. They usually come right back on. So we just, instead of going through that and for the member and for providers, because now you all can pretty much rely on that 12 months continuous coverage, it helps cut down on that churn. So we moved cases with children and redistributed them from September to April through the rest of the unwinding so that we could implement in the system that automatic continuous coverage. So large number in September. I think what you'll see is 2 things I want to point out. One is some good news about terminations, and that is where we're having a high number of procedural terminations. And those are ones where generally the member hasn't responded to a notice. So we have to terminate because we can't do a redetermination without the information or verification of the information. The good news for September is a little over 15,000 of those terminations were actually individuals determined ineligible. So we had a really low number of procedural terminations in September. Part of the reason for that is you will see on the far right, that bucket of pending. There's a large number of members pending. One of the flexibilities we have implemented for unwinding is to extend someone. So if you're a long-term care or 1915C member, we can extend up to 2 months if you've not responded to a notice. So that means, for example, if they had a September renewal and we didn't get a response from them, we can extend them to October. If we don't get a response in October, we can extend them to November. But at the end of November, if they haven't responded to that notice, then we'll have to terminate. So for those members, they get 2 extra months. For all other members who did not respond to notice, we can extend for a month. So September was the first month that we implemented the extension for all members for 1 month. So that's why there's a larger pending bucket. The reason for this really is to continue outreach to them, to get them to respond to that notice so that we can do an actual determination of eligibility for those folks. I want to highlight a new report that's coming out. We're going to be doing this every month, starting with September renewals, and it's a demographic report. So we can deep dive a little into, what the population looks like from race, ethnicity, gender, and age. So we will be posting these on a regular basis after the close of the renewal month. It's a good way to track who we're seeing across the state, and then by that demographic. I talk a lot about reinstatements because it's really important for everyone, members and providers, to understand that if somebody walks into your office and has just been terminated from Medicaid, if they can go back and respond to that notice within 90 days, we can reinstate them, no questions asked. No need to request that reinstatement. We'll reinstate them back to their termination date if they're determined eligible. So, as you see folks come in and they've just been terminated, and if they didn't respond to a notice, then they can provide that information to us so we can complete a determination for them. So we're tracking those, that 90-day period. Of course, May renewal 90-day period is closed, but we did have 5,600 come back in during that period of time. So the most recent September renewal, as of October 13th, we had a little over 1,700 that were reinstated. So just encouraging those folks terminated for a procedural reason of not responding to a notice is an important thing. Just reminding everyone that we do still have a lot of flexibilities. There were flexibilities we implemented for public health emergency that ended on May 11th, but we have a lot of flexibilities we put into place as we unwind. And they really all are targeted towards the increasing our ability to automatically redetermine somebody, or to reduce the number of procedural terminations for lack of notice, responding to notice. As I mentioned, the extensions are a flexibility we have approved through CMS, and there's a whole host of them. We are doing our best to take advantage of the flexibilities and strategies that CMS is offering to states so that we can ensure that we're not inappropriately terminating somebody who is otherwise eligible. So we have all these on our website if you're really interested in seeing what some of those are. I mentioned we're focused on reinstatement. We just created this new flyer. It's something that as providers, you guys could pull down and have available. So if somebody walks in, you know what information they need to move forward with possibly getting reinstated post-termination. It's on our website, so feel free to pull those down and use them, as appropriate. And just a reminder, we do have a lot of other information and informational flyers and other resources on our website. So they're there and available for providers to utilize in your offices. If there's something else you might need, please reach out to us and let us know. We're happy to tweak some of these to your particular needs and how you're supporting and helping your patients navigate this, unwinding the restart of renewal. So we really appreciate you guys doing that. Just a reminder that members' redetermination date, if they're subject to a redetermination, not all members are subject to redetermination, but if they are, then their redetermination date is on Kentucky Health Net. So as you're verifying their eligibility and they're getting ready to come into the office, it's something that you could check.
Hey, Veronica, this is Barry.
Yeah.
So the qualifications has not changed as far as the poverty level guidelines and things of that nature. It's just the requirement of them to take some kind of action to be reinstated, right?
So there's a nuance to that. So the federal poverty level hasn't changed, but what we're doing during unwinding, we have a lot of flexibilities where there might have been, for example, a requirement to seek childcare, or there might have been a requirement to I'm trying to think of all of our flexibilities. I'm blanking, but we have some
verification
other
of
things
income.
that would have maybe determined it was a requirement that would have made them ineligible, but during unwinding, what we're strictly looking at is income level, pretty much. So some of the other reasons why members might be terminated, we've been able to waive during unwinding.
Well, there's a misnomer that the qualifications have changed, and that's why so many people are rolling off. And I'm trying to explain that is not the case.
Yeah, I think along those lines, what's important to remember is that during the public health emergency, when we were having continuous enrollment, we did see that people's income increased, and those really are the folks that are primarily being determined ineligible, is because their income has increased above the federal poverty level. But the eligibility limits for individuals, depending on, if they're pregnant, a child, or an adult, those have not changed. And we're still, again, folks still have to meet those income limits.
Okay.
To help. Speaking of income, if someone is over the Medicaid income limit, they are likely eligible for an advanced premium tax credit, or otherwise known as APTC. And that makes a qualified health plan on Connect, the marketplace, our state-based marketplace, much, much more affordable. In fact, sometimes you can get a tax credit that completely pays the premium. And then there are also other cost sharing financial incentives for members to make cost sharing also either zero or very low. So we are encouraging folks that drop off Medicaid due to income to go and apply for that qualified health plan and choose one, so that they can maintain coverage. If it's not Medicaid, then we want to see that they're enrolled in at least a plan, that a no cost or low cost plan to maintain that healthcare coverage. And what we have seen is a growing trend. This is a great line, because the line for Medicaid eligibility is trending down, but the line for QHP, qualified health plan enrollment, is trending up. So that's good, because Kentucky has historically had a very low uninsured rate, and we want to make sure that we're not increasing that rate during the unwinding. So there's a lot of information on our website. If it's somebody that you're one of your patients that's no longer Medicaid eligible due to income, encouraging them to get coverage through the Exchange Connect would be great. Website, I always promote the website. It's out there and available, has a lot of resources on it. So please check that out. And then, of course, I always remind everyone, if you can follow us on social media, you don't have to do all three, but maybe like us or follow us on one of them. It's where we post the most up-to-date information. We have a stakeholder meeting once a month, that third Thursday at 11 a.m. If you can't attend on that day, because I know you're seeing patients, we post it on our web. We record it and post it, including responses to any questions that come up. So we certainly encourage folks to utilize that to stay informed. So probably went a little longer than I should have, but it's a lot of good information just to remind folks. Oh, Stephanie, I can't hear you. There we go.
A little trouble there. It is good information, so we appreciate that update, Veronica. Thank you.
You're welcome.
One question that I had was, we know what the conversation is in the primary care community. Do you know what the conversation is in the hospital or specialty community? One thing that we saw early in the summer were patients who had been referred and were waiting for appointments that they had terms between the time that they were seen in our office and when that specialty appointment occurred, and those appointments were just getting canceled. When in reality, if they did a little work, they could help that patient get re-enrolled.
Yeah,
So
I appreciate you asking that question. And in fact, we have been working with the Hospital Association specifically, and it's a conversation we have with the long-term care community about the fact that, you know, because of the redetermination process, we certainly we have shared guidance with connectors, which are the folks that, and insurance agents, which are the folks that can help members navigate the application renewal or redetermination process, to make them aware of the fact that they should escalate. If somebody has an appointment scheduled, they can ask for an escalation, and they know how to escalate cases to us. So I do recommend that if one of the best things to do is to help that patient know that they can seek a connector. And we appreciate the Kentucky Primary Care Association does have, is one of our contracting agencies for connectors, but they are in all communities. And to maybe connect with a connector so that they can escalate that test, and we can make sure that we get that process quickly if somebody's been terminated. But we're creating something specific for the Hospital Association around that, because it had become a problem. I think through our education and outreach with the hospitals, maybe it's becoming a little better to know that, you know, please don't cancel that appointment yet. Give that individual the opportunity to work through that redetermination, because we do see a lot of folks come back on.
And we've, you know, I know in our office, we've tried to work with our referral clerks and have them check that, to have that communication proactively, but it's still tricky.
I appreciate that so much. And we know a lot of providers are really going above and beyond, and we're so grateful for it.
Yeah, Veronica, we are really grateful to have the Connect program and be a partner in it, because it's a great benefit for our communities.
Thank you, Barry.
Any other questions about redetermination? All right, so let's move on to the updates from the RAP work group. Are you doing that, Veronica, Dr. Hoagland?
Yes,
Okay.
I'll take the first one. The MCOs can speak for themselves. So I've completely failed you all, but I had, I think, committed to getting the reconciliation guidance out not long after our last meeting. It is finished, and there's a provider letter that's been developed, and that should be coming out any day, and I'll send it around to we'll send it to the MAC and TAC so that they have it. We're just waiting for a signature on the provider letter, and as soon as that's finished, we'll be able to release that. I think our next step with that is just monitoring. So I'm going to acknowledge that this is our first iteration of the guidance, and our hope that it is something that is useful. It's a useful tool to both providers and the MCOs, and of course to DMS, in how we can reconcile RAP payments and including historic ones, historic issues. So I think as we move through, we're going to closely monitor how the process is working, and are certainly open to, you know, reviewing that and revising it as needed. So I want to make sure you all know we have that commitment. You have to start somewhere. So this is our starting point for the guidance, and we really look forward to, moving forward with it and hoping that this is something that is going to be beneficial to providers. Just know that providers were at the table and helping us craft the guidance, but everybody's situation is different. So as you get it and are working through it, just, reach out. There's contact information. There's an email box for DMS. There is contact information for each of the MCOs. So you know who to go to reach out if you're having an issue with a RAP, because there are, different issues, and we've tried to provide scenarios and on what those kind of common issues are, so that you all can take a look at that and use it to help you resolve it. So that should be out like I said, it's final. We're just waiting for that signature. So, but we will be continuing to have the RAP work group meetings, because there are still a couple of things, that we're trying to resolve that we consider to kind of be, systemic issues. So we're going to continue to look through those and resolve them. I know dental claims continue to be a challenge. So we want to stay as a group and monitor those issues. And then, as I mentioned, if we start to get feedback from providers that the guidance really isn't working and the process isn't working as planned, something we would want to take back to the work group and see what we can do. So, so we just look forward to getting that out and having you all utilize it.
Thank you. I think the Humana processing delay was mostly resolved when we met last, but it was on the reprocessing. So is there an update from Humana on the progress of that work?
Yes, hi, this is Samantha Harrison. I'm the operations officer. I'm not Herb though, guys, so he is the expert here. We just received notification that the final IPAR, which is our claims reprocessing project status, was completed. So right now our encounters team is evaluating those claims for submission in the coming weeks to send to the department as an encounter. We're hoping all will be accepted, and then it's in the department's hands to review for the criteria and submit RAP payments for those providers impacted. So it's great news.
Thank you. Melina, DentaQuest validation.
Sorry, I was on mute. Yes, that project is completed.
Okay. All right. And lastly, the UHC OB ultrasound encounter submission project.
Hi, this is Dr. Cantor. Sorry about that. I'm sorry, was there a question? I thought this topic was concluded last cycle, the last TAC. So I'm
Sammy, do you have an update from our side? Do we agree that that issue has been resolved?
Yeah, good morning. Yes, I think the issue with the UHE systematic issue that was causing the bundling has been corrected.
Okay.
We haven't confirmed that claims have been reprocessed, so that's just what we're waiting for. Dr.
okay.
Pan. Yeah.
Okay. I'll take a look into that. Thank you.
Thank you. Thank you.
So we'll leave that on the agenda for next month, just to confirm that those claims get reprocessed. So moving on to new business, DMS updates.
That's me again. Hello. So we do have a lot of things going on, a lot of projects. I think one thing I wanted to note is that we just had our state plan amendment for what we call treat, no transport, as well as treat, triage, and transport. So what this is it allows emergency medical services to provide services on site and right now they have to actually transport somebody to be reimbursed, but they can treat somebody on site and not transport and still receive a payment or a reimbursement for those services. So we're kind of looking forward to maybe diverting unnecessary trips to the ER as a result of this. For the treat, triage, and transport, this actually will, as we work to implement this, which is not until next year, but when an emergency medical service arrives, it is possible that they could transport the individual to a non-ER site. So it could be to a primary care center, to a FQHC or RHC. It could be to a community mental health center. So again, this is just trying to get to the individual to the right setting. That's not the ER. So you will, as we start to roll this out, you'll hear more about it. The treat, triage, and transport is going to be in part as part of our mobile crisis new model. Again, this is something that we're hoping to launch early next year, that will start doing more stakeholder engagement. So we'll start reaching out to providers and talking through what that looks like. If a crisis team responds to a situation, again, they might be able to transport that individual directly to a provider that's not an ER. And that also is not maybe a crisis stab unit, but rather the person, they've been able to handle the crisis and then get the person to a provider that can provide the next necessary services that the person may need. So you'll start to hear a lot about that. Again, we're finalizing some of the details, and then we'll start working on an implementation that includes a lot of stakeholder engagement. So that's really the couple of things I just wanted to highlight. But happy to take questions about anything Medicaid. Dr. Hoagland, I see your hand up.
Madam Chair, if you wouldn't mind just me asking a couple questions on this. It's really interesting, and it sounds a bit like some of the paramedicine programs that have worked as kind of pilots in Kentucky, but in other states have been active for some time. I guess it's an extension of that, and to simplify things for me and us, Senior Deputy Commissioner.
Yeah, I would say that the paramedicine model, and yeah, there are some really great programs in Kentucky that we have drawn from as part of our statewide model. But it's really even more than that. Because we're really trying to think of all the different inputs to a crisis. So the 988 call will be connected to it. It could be EMS, but it could also be a crisis team that gets dispatched. We're going to be working with law enforcement. So, sometimes that call goes to 911, but we will actually be connecting to 911 as well, and working with our law enforcement partners on, maybe this is a call where somebody with behavioral health expertise needs to go as well. So, again, diverting the unnecessary law enforcement calls and diverting from the jails. So it's a really comprehensive, it really has not been done in any state. The way that we have put this model together and trying to capture all the different inputs to somebody going through a crisis.
I appreciate that, and I understand that it's in development to some extent. Would you anticipate a new provider type for this, or just a particular certification or licensure at the state to participate?
Yes, thank you. So there is going to be a new behavioral health transport provider type, so that we can reimburse for that kind of new way of transporting someone. But other than that, we will be leveraging all the other providers in their current provider type. We're just expanding how we get maybe a patient to you. So there won't be any requirement for any of our current providers like FQHCs and RHCs to have to do anything different.
Okay. And so I guess, theoretically, obviously on the receiving end of the transport, but could potentially be on the front end of actually helping facilitate the on-site service and then the transport to brick and mortar of their own facility conceptually is a possibility.
That's correct. That's correct. And I think it's important to mention that we did a procurement for an administrative services organization, an ASO that is going to administer this program. And so that ASO will be reaching out to providers who are interested in being part of the mobile crisis response as part of this new model. So, any provider could step up as long as they meet, the fidelity of the requirements, could step up to become one of those providers. Again, this is a statewide, we're going statewide with this. So we're really going to need providers. And that once the ASO is on board, they're going to start reaching out to providers and having those conversations and having those stakeholder meetings to explain more about what it is and how it's being implemented.
And sorry to monopolize this segment here. When do you anticipate that ASO group to come online?
We're finalizing contract now.
Okay.
So I expect we probably won't do anything during the holiday, but so I expect 1st of January.
Okay. Very good. That sounds like a group that we'll want to follow up with for sure. So,
absolutely. Yep. And we have a long list of providers we absolutely know we want them to engage with, and Kentucky Primary Care Association is on the top of that list.
Thank you.
For those of us practicing in rural communities, treat no transport is exciting because there are regularly occasions when there's no ambulance in your community and you have a patient who really does need to urgently go somewhere. So that's exciting. Any other questions from DMS for DMS?
I have nothing else. Thank you.
All right. So moving on to the update from the KPCA, Dr. Hoagland.
Yes, thank you. So the mention of the connectors was very timely. For the group, just wanted to update that, as part of the contract with the Commonwealth, we have the KPCA has been recruiting connectors to fill positions. First, looking at embedding connectors in the local community and technical colleges. There are the 16 kind of regional branches of that, and so 16 positions are being recruited, as well as management for those staff. Currently, we have been able to hire and onboard 11 of the 16. So not there all the way, but getting closer. And so I think that is a good opportunity for different communities to have access to additional resources to help make sure that people are able to obtain and maintain their eligibility for insurance. So excited about that and happy to be a participant in that process with the cabinet and the Commonwealth. We're also recruiting 2 positions. It's a bit of a pilot to go into some of the state offices actually in Jefferson County. Be based primarily at the L&N building, for those of you that are familiar. Again, it's more of a pilot working with DCBS and the cabinet to see how that works. Depending on the success of these models, there's an opportunity to expand. I don't want to get out over our skis here. I think the first thing is make sure that what we're bringing online is successful and meeting the needs of the citizens of the Commonwealth, the cabinet, and then obviously the downstream effects to providers, allowing them more flexibility as the patients they're seeing have a third-party payer in place. We're really excited for that opportunity to collaborate. But I pause there to see if there's any questions from the committee members on that particular topic.
I think the connectors out in the community college is a great outreach.
Because of the natural spread and regional nature of those, it seems like a really natural fit. Working through the different administrative processes has been fun for team members, but I think that's largely been addressed at this point. So again, I think it's just a really natural fit, and looking at systems that are already in place rather than recreating them certainly makes a lot of sense from our perspective as well.
It's a good avenue.
A couple of other things I'd like to just update the group on. You'll recall that the association was a convener for a grant from the Department of Public Health, coming from the CDC for mobile units that are being distributed to certain members of the association. Long awaited, supply chain hits everything, including mobile units. And so I believe 6 to 9 of the chassis have been constructed and delivered to the upfitting vendor that is unfortunately in California. But they are in process of being upfit to meet the needs of a mobile clinic. That part of the use for those will be to help administer vaccines. They also are part of a mobile response to natural disasters and other crises across the Commonwealth. So we're looking forward to having those back in Kentucky. It's really interesting. They're built in Louisville and then shipped across the country to have the retrofitting done. That's just the way it works. But we're excited for the first ones to hit Kentucky for use, and we anticipate that to be late spring, early summer, and then we'll continue to trickle through the remainder of the year. So just an update on that. Lots of conversation around vaccines, child and adult, commercialization of the COVID vaccination series has been, first and foremost in the minds of a lot of people. Initially, there were some challenges with distribution of the vaccines, and a lot of that has been resolved through some direct from manufacturer fulfillment to clinics that have had need. We've really appreciate the assistance from the Department of Public Health and the cabinet and helping get information out to the people who are actually putting shots in arms, and helping make sure that there is appropriate access to vaccines for them to administer. What I hear primarily is that a lot of the distribution issues have been addressed at this time. It does seem like there are different types of issues on the consumer side about hesitancy of receiving the vaccine that varies from community to community and vaccine to vaccine. So that is really interesting, and I don't think there's a single answer for that other than consistency and training and trying to address some of the myths that are out there and misinformation, which is always a challenge in the age of social media. But I think kind of continue to work towards a level playing field of understanding and health education is really important. As a kind of a side note to vaccines, that's led to a really, I think, fruitful conversation. We were approached by a couple of our groups about rabies vaccinations, which luckily is something that we don't have to deal with every day. Coincidentally, though, that tends to be part of the reason why there is some confusion about how that should be best fulfilled. And that led to some conversations with the Department for Public Health. There is a veterinarian within the department that is leading the rabies exposure and vaccine and treatment response. She's a wealth of knowledge and has graciously offered to help provide her time for training for other individuals. What we have seen is that it appears that in some communities where, well, I mean, most communities, it's not something that happens every day. And so a person presents to the emergency department and is evaluated, risk assessed. The local health department is notified for tracking whether the animal has been captured or not, entered into a protocol. The first dose of the vaccine, if needed, and immune globulin is provided in the emergency department. And then they are discharged to the community for follow-up. And that's where the gap appears to have occurred. And we're working through how to help with that transition of care. So there are agreements apparently with Walgreens and Kroger to be able to provide those vaccines to the patient, or to help get them transferred to the provider, their clinician, to administer the shots. They have a drop ship mechanism to be able to fulfill and receive the vaccine and then administer it. But what has happened is that place of where should they go to get the follow-up vaccines and completion of the series has been a bit of the challenge, where people have presented to their local clinicians wanting the vaccine and they don't have it on hand, and are not exactly sure how to fulfill that. So we're working on kind of closing that loop. Part of the fruitful conversation beyond that, working with the Department for Public Health, has been a conversation with the Kentucky chapter of the American College of Emergency Physicians. And they're very interested in this and other topics. And I think it's a bit of a newer engagement for us talking with them, but I think they can be really helpful on a number of activities. We tend to connect with the hospital association as the brick and mortar. The physicians that work in those facilities often are not employed by the facility. They tend to operate as in a contract relationship, and going right to the organization that represents them, I think, is another conduit of getting some information. And they also, those groups that provide the contracted services tend to operate at multiple facilities. And the turnover tends to be a little bit less than at the facilities themselves. And so what we've found is that these situations that occur sporadically that are not retrained on, the institutional knowledge moves away really quickly, either because of just attrition of staff, or that it just falls out of memory because there's a lot of other things that have a higher priority. So we'll continue to work through that. But I do think that the Kentucky chapter of the American College of Emergency Physicians will be a much more common group that we interact with to try to help with some of these issues that are kind of a transition from urgent emergent care to our facilities. So I'll pause there.
Well, Steve, one of the main things is if Medicaid and the MCOs could change their fee schedules to reimburse the amount that we would have to be out, is the first step. Because right now, we have to go through an adjustment mechanism with the MCOs to get it paid for, because the Medicaid fee schedule is well below the cost of the meds. That's a starting point.
Okay. Duly noted. And not to speak for the committee members, but I guess, that could be a potential recommendation, is, evaluation of some of these less common treatments and vaccines. As costs have increased, what is the fee schedule and the reimbursement appropriate? So an analysis of that. Not to put words in your heads.
I mean, that's what I am asking is for Medicaid and the MCOs to review that. I don't think that really has to be a recommendation for MAC. It could just be a recommendation to our existing participants right now, because that seems like that could be an easy fix.
Yeah, I think we always want to know if especially for coverage of drugs, if we are, our intent is always to cover the cost. So if there are particular drugs that we're not doing that, or vaccines that we're not doing that for, then certainly we're happy to take a look at it. Doesn't need a recommendation, but we'd be happy to take a look at that and include
The
our
health department
pharmacy team.
have kind of made a concerted effort to ease out of that.
That's right.
That kind of laid it on the primary care providers. And
Yeah.
now the primary care providers, it's such an infrequent occurrence that when we do get hit with it, then that prompts us to, that causes a delay and forces the patient to go back to the ER, which doesn't help anybody at all. So
Right.
if we could put that little stopgap in right now, that would help. But the bigger picture is, when they have to have a series of 3 shots, what if they don't come back and get those shots? Where do we get the meds? Can we send the meds back, get a refund? There's a lot of other logistic issues, but the main issue right now is to get the fee schedule appropriate, where whenever we have one, we get the meds, we're able to bill for it. We don't have to negotiate with the MCO and get an authorization for the additional amount.
It's certainly something we can work on.
Okay, thanks.
Yep.
Additional comments or questions about Dr. Hoagland's updates?
Stephanie, I do have a couple of others, if that's okay. Just to follow up, a previous meeting, we had approached the department about a data request, just to update the group that we've had a couple of meetings with their clinical quality and data teams to work through that. Yeah, we don't have the actual data in hand yet, but we're working through the process and want to make sure that you're able to answer with as much specificity as possible the questions that we have. So I just wanted to update the group that has been ongoing, and it's been a fruitful conversation, and they've been a very willing partner in that process. In the interest of time, I'll just give a quick high level on some of the things that we have been seeing kind of across the landscape of the association and the network. For those the guests on the call, there have been a really pretty significant systematic approach from our members to look at engagement of their patients and clients, and particularly those that have not necessarily been seen frequently or ever from that perspective. And we have seen that over the past quarter, the number of patients that are measured as being not engaged, that is, they haven't been seen over the past year, has been trending down. Now, some of the questions that we don't have the answer to yet is that partly because of some of the redeterminations, and if those people, were kind of lost to follow-up or lost to care, were they losing eligibility as a result of procedural issues and processes that Veronica was mentioning earlier in the redetermination process? We don't know the answer yet, but I think it's one of the things we need to look at. Is it, a loss of eligibility that has then created the coming out of the attribution number? I mentioned attribution. It's something that is near and dear to all of our hearts. And I think one of the opportunities for us to think about over time is, can there be a more consistent way of defining the attribution process within everyone's systems? Right now, there is a variance between how that is being done outside of member selection, client selection. What is the process? And then what is the reconciliation process on the other side? It's widely varied across all the different payer types. So I don't know that we have to push for something right now, but I think it's something that we need to have on the radar to consider. That's a place where, in my mind, there's not a lot of opportunity for distinction, but consistency can really help in measurement and moving the entire program forward. Some other just quick things to mention, across the association membership, we're seeing that pharmacy trends continue to increase, not dissimilarly from what's happening nationally, but it is something that is having an impact on the kind of on our performance within value-based programs. Another driver of both utilization and cost or behavioral health utilization. And I think we all want to be very thoughtful about what that represents. We in general, there has been under recognition and under treatment over the past decades for individuals or for people who live with significant behavioral mental health conditions. And so access to appropriate services is something that's really important for long-term health and well-being. Making sure that that's matched and it is appropriate is something that we're all need to be thoughtful of, and that should be the case whether it's a behavioral health condition or service and a medical health condition and service. Parity is extremely important for all of us. But I just note that trend has been increasing over the past several years, but it continues into this year. And with that, I would stop and entertain any questions from the group.
Right. Hearing no questions. Thank you, Dr. Hoagland. The next item under new business is wrap payment topics, but we discussed that in old business. So unless anyone had anything new to bring up, I sort of feel like we may have already addressed that for today. All right, so we will transition into updates from the MCOs regarding quality programs for 2024. We will begin with Aetna Better Health of Kentucky.
Good morning, everyone. My name is Susan Vickers. I'm the lead director of quality for Aetna Better Health of Kentucky. My power just went off like 3 minutes ago. Transformer outside of my window blew. Are you available to go first, and then I can come in right behind you, my friend? I'm not sure if you're on.
This is Stuart. Are you inquiring if I could go on, Susan? I'm sorry, you broke up a little bit.
I said my power transformer just blew outside of my window, and I'm almost reconnected to my PowerPoint, but calling in from my phone to see if you might be able to go first, and then Aetna will be glad to go second if possible.
I'm good to go if the leaders would allow that.
Yes, that's fine.
Thank you for your patience. I'm so sorry.
So Stuart Cox, if you can allow me to share, please. It shows host disabled screen sharing.
Give me 1 second. I apologize.
Okay,
My
no problem.
Zoom account today is I'm trying not to crash the whole meeting. Just bear with me 1 second. I do apologize.
No problem.
Okay, you should now be a co-host. And if any of the other MCOs need a screen share, if you'd like to drop your name in the chat, I can work on that while Anthem is presenting.
Okay, if you can confirm, please, if my screen is sharing. That's a yes. I'm sorry, my configuration changed here, so my video.
Yeah.
Okay, thank you. Okay, so for 2024 quality focus, 3 major components to that focus for Anthem, and they align very significantly with the state directives that we have in play. Number 1, first being the new value-based purchasing quality withhold program. There will be a quality withhold and a bonus elements to that for 2024. Second will be the managed care quality strategy that was implemented in 2023 by the state. And in that, I'll share with you, we've got a lot of overlap with our HEDIS work groups and our whole health, population health domain teams and how we're approaching our quality initiatives there. And then third, there's a new PIP, Performance Improvement Project, directed by the state for 2024. That's a dental PIP that'll be focused on new measures for NCQA HEDIS. That's the OED, oral exam dental, and the topical fluoride for children measures. First, on the value-based purchasing, though, the quality withhold program that's been shared by the state, that's now been socialized pretty well out there. The primary direction we're taking on that is looking, at our provider value-based incentives that we've had in place previously, making sure those measures related to the withhold program of the value-based purchasing are included in those provider incentive programs. Addressing and looking at updates to our member education, and particularly our incentive, our Healthy Rewards incentive programs, to make sure those are relative and focused there. And then since a large percentage, 70% of the weight for the withhold measures are around children, particularly well child and vaccinations, that's going to be a primary focus area, working with primary care and pediatrician providers out there on how we can help make sure we get engagement, breaking down barriers to access for appointments and slots, and making sure we get kids in. And that gives the providers then that ability to have those discussions with parents, with the children of all ages around the preventive care, the weight assessment screening, and then the overall outcomes and with vaccinations. So there's 6 withhold measures there. Everybody's aware of these: the A1C good control, well child visits, the CIS flu vaccinations for the younger children, 2 years old, the IMA HPV vaccinations for combo 2, although the first year of the program is going to be focused on the combo 1, the meningococcal and the Tdap vaccinations, and report only for the HPV portion, but that'll resume in the next year. PPC postpartum, and then the new SNSE social needs screening measure, and that one will be report only in the first year. So, and then the 4 bonus measures, and the metabolic monitoring for kids and antipsychotics, the FUA7, which is the SUD ED utilization 7-day follow-up utilization measure, WCC nutrition counseling, and then the breast cancer screening. So next, in the managed care quality strategy zone, we've that new strategy was implemented this year, and we are working heavily to make sure that we integrate anything related to our HEDIS STARS program, all of our HEDIS measures as appropriate, our HEDIS work groups there, our whole health and population health domains, and we have focused areas that we go deeper on health equity and all of the social needs opportunities, SDOH related opportunities to help remove barriers to care as we focus with the measures themselves for HEDIS. And then our health equity program, looking for opportunities where we see in some of our measures overall good, particularly with maternal and kids, we're seeing opportunities where we may have good overall results on our HEDIS measure movement, but with the African American or some of the other race ethnic breakdown, we may have some opportunities in some regions in the state. So overall, there's the goals are I've listed here. The categories, they're very similar to our overall to the categories in the value-based purchasing. We do have a meeting with the state to go over these. On the 8th, all the MCOs will be meeting. So there's going to be some specifications there that we'll be getting some download on and discussing with the state as well. So there'll be more details after we have that meeting and that. But those overall categories: behavioral health, disease, chronic disease management, preventive care, health disparities, and social determinants of health. And then finally, we wanted to just bring up this PIP, this new PIP that'll be in place for next year that all the MCOs will be working on. The topical fluoride for children, particularly PCPs and their clinical staff, can apply that fluoride varnish in their offices and receive reimbursement for that. That's not just for dentists. And one of the questions, this will be eligible for children ages 1 to 4. So that one question that this TAC could probably help us with some discussion and feedback on is related to what are those opportunities and barriers in applying that fluoride varnish actually in PCP or in pediatrician offices on that. So any questions on Anthem's program for 24 for quality?
Hey, Stuart, this is Leon. I just wanted to introduce during the presentation of some of this material to our Physician Advisory Committee, we received feedback about the importance of us making a change to allow for the simultaneous billing of well and sick visits. And so what we are beginning in January, we've had to do this very carefully to be able to stay with the information as outlined in the law, but we will be making some changes to our system so that as the providers address both if during a sick visit, be able to do what they're able to do for well visits, to be able to accomplish some of this information, to be able to do the incentives or the vaccinations and so on and so forth that are clinically appropriate at that time. We're making some changes where we will be paying a multiple of when both services are rendered and the modifier used, we will pay an extra amount for one of the services that help to compensate for the second of the two services. So there's a little detail in there, us having to stay with information as outlined in the Code of Federal Register and within the Kentucky rules and regulations. We're technically not allowed to pay for both of those services, so we're not, but we're paying more for one of those services when both of those services are rendered. I hope, Steve, you may understand the nuances of what I'm trying to present there. So, but that came as feedback from some of your colleagues, and we're hoping that change within our administration will help to make it easier when we've got those members in the office. Let's do all we can to take full advantage of their time with us.
Any other questions, please?
Were you asking for feedback now about the fluoride during the medical visits?
We suggest that could be tabled and then an actual topic for discussion as we go on. It doesn't have to be addressed right now, but that is a question that we thought appropriate to get some ideas on barriers and opportunities for that might help all the MCOs to how we approach that.
Sure, we can work on that. Thank you.
Okay, thank you.
I don't see where Aetna's logged back in. Oh, sorry, Stephanie, you were talking. So if one of the other MCOs would like to continue on.
Yeah, this is Tabitha with Aetna. Susan's been messaging me. She's still trying to get logged back in. She said if you just want to move her to the end, that would be great.
Sounds good. Dr. Moyer, are you ready?
Let me share my screen. So I get a thumbs up that you guys can hear me. Good. Yes. Okay. Sarah Moyer, I'm the Chief Medical Officer for Humana Healthy Horizons, and I oversee our quality program for Stingel-Sy. And I am sharing the wrong screen, so let me switch. Thank you. Stingel-Sy leads our quality program. I think she might be joining here in a few minutes. She had a conflicting meeting, but happy to share what we are doing in 2024. So really focusing on improving the quality and health of our members. In Kentucky, we've got a comprehensive approach that really try to improve our quality rankings by developing and implementing data-driven outcomes, based continuous quality improvement processes, and collaborate with our internal and external partners. So with that said, just really appreciate all the feedback we got last year from KPCA and our FQHCs on how we can improve what we're doing here at Humana. So as Anthem mentioned, focusing on the 10 measures that are in the new value-based program coming down from the state. So that's hemoglobin A1C control, our well child checks, our immunizations in our babies, as well as the adolescents. And then the social needs and screening will be monitoring for 2024, but tracking postpartum care and the metabolic monitoring for children and adolescents on antipsychotics, the 7-day follow-up after ER visits for substance use disorder, and then the weight assessment and nutrition counseling in our kids and breast cancer screening. I'm going to be doing this through the data-driven proactive approach. I'm really trying to identify our high-risk members timely. So those that have social needs, those that are visiting the ER, have high chronic conditions, high-risk pregnancy, post-discharge follow-up care, really trying to meet our members where they are, and especially focusing on those that have higher needs or historically have had bigger gaps in our data outcomes. We're enhancing our reward program and our value-added services to promote healthy behaviors in 2024, and as well as enhancing our PCP quality reward program and our value-based contracting program, focusing on these 10 measures, as well as having new metrics for different NCQA percentiles if the practices meet those, as well as payments for improvement as well. We've got different programs for the adult measures, the child measures, and new for next year will be maternity measures as well. Also enhancing our member engagement and care coordination to address not only the gaps in the metrics, but also social needs, as we know that helps get our members into your offices, so health improves overall. And as always, our team's here to provide engagement and support. So we'd love to meet with you. If you're not meeting with us on a regular basis, please reach out. Like to identify members that have gaps, and especially those that you struggle to get into your office to see. So we've got tools and data, and we'll be enhancing that next year as well. So just looking forward to seeing some improvements in 2024. I think the only other thing to add to is also doing the dental PIP that Anthem mentioned as part of our 2024 goals as well.
Thank you. Are there questions for Dr. Moyer? Hearing none, we will move on with Passport.
Hi, good morning. Let me see. There we go. All right, confirming you can see my screen? Yes, okay, great. So I'm Michelle Weichel. I am the AVP of Quality and Risk Adjustment for Passport by Molina Healthcare. A lot of the content I think is going to be similar across the MCOs. So if we get a little bit repetitive, apologize in advance for that. The way that we broke out our initiatives going into 2024, we're looking at strategy, member engagement, and provider engagement. In measurement year 23, 89% of the 10 value-based measures that Dr. Moyer just went through, Passport had year-over-year improvement. Strategically, we've been building infrastructure so that SDOH and health equity are foundational to all of our processes. We created collaborative clinical quality work groups so that we were looking at an issue across departments. So we have a chronic condition work group, we have a maternal work group, a peds work group, an inpatient, like a utilization ED work group. So we're trying to look at the condition or the problem, whatever's going on with that particular population at that level, and then bring in clinical, network, quality, et cetera, community engagement, so that we are all focusing on the same thing as opposed to being in individual silos.
Michelle, I just wanted to interrupt you quickly and let you know, we're now seeing your SharePoint site, not your slides any longer.
Okay, how about that?
Yes, now we're
Yeah,
back.
yes.
Thanks.
Yeah, sorry about that. I moved it so I would be facing my camera, and that didn't work out. So from a member engagement perspective, like Dr. Hoagland mentioned about the challenges of members being assigned to a primary care physician and then the practice actually never seeing that member, we have 70% of our Passport members have had a PCP visit so far in calendar year 2023. Going into 24, we're expanding our member outreach, again, supporting those value-based quality withhold measures from DMS. So there's going to be a significant impact, a significant focus on well child. 70% of the value-based value from DMS is assigned to well child measures. So well child visits, child immunization, adolescent immunizations, and then nutrition counseling. We have expanded our member healthy rewards, again, looking specifically at childhood and adolescent immunizations. The big challenges there being the childhood flu for kiddos under 2, they need 2 flu shots. That's the challenge for that one. And then in the immunization for adolescents, HPV is definitely the challenge there. DMS has made some changes going into 2024 at the adolescent immunization that we're looking at, but we continue to work on HPV. That's something that everybody, I'm sure, is very well aware of, is a challenge nationally, but specifically in Kentucky as a conservative state. We are rolling out a transportation pilot specifically in West Louisville, as we have identified from our subpopulation analysis that the membership in West Louisville is definitely a cluster where well child and immunization compliance rates are lower. So we're trying to address transportation as a barrier, and we are rolling out a pilot where we are contracting with a West Louisville minority-based transportation company to specifically target that particular area. We're partnering with the Louisville Metro Department of Public Health and Wellness so that we can extend hours for immunization availability. And Passport will be participating in that by actually sending clinical staff that will be administering immunizations. We are expanding our Care Connection visits in 2024, and those are our nurse practitioners that do in-home visits for members. A lot of the time that is looking for members who have chronic conditions that are not regularly seeing their primary care providers, but we are specifically looking to target postpartum moms that haven't come in for their postpartum visit and trying to see if we can address that compliance challenge by sending nurse practitioners to the members' homes. And then lots of community engagement work with churches and local events of trying to engage Passport staff with reaching the members where they are and trying to talk to them not just about quality care gaps and how to engage as an advocate for their own health, but certainly we've talked a lot about redetermination and how do they get themselves engaged in that process if they've let their eligibility lapse. And then finally, provider engagement is a key pillar to Passport in having a successful quality-focused strategy. Currently, 64% of Passport's members are assigned to a primary care physician that is under a value-based contract, which is our provider P4Q kind of program. Value-based providers outperform providers who are not in a value-based contract 100% of the time on our targeted quality measures. And they have a 3% absolute percentage point higher rate of members coming in for their wellness visits. We do have a diabetes sweepstakes that we rolled out in 22 that we are continuing. That's for eligible primary care physicians can become part of the sweepstakes, and based on their A1C results, they can be in a raffle to win a RetinaView diabetic retinal eye camera, so that they could do retinal eye exams in their office. And then, you know, there's definitely challenges with diabetics receiving an eye exam at all, or they go do an eye exam at VisionWorks or something, and the primary care physician never has an opportunity to learn about that or what the results of that exam were. So RetinaView is a great option, and we're really excited to be able to offer that sweepstakes again this year. I think everybody's covered that. Passport will also be updating our value-based contract to support all 10 measures that are in the DMS value-based purchasing program. Lots and lots of education already occurring about the new SDOH screening measure, SNSE. That HEDIS measure is calculated in a way that is not normally how primary care physicians think about how to document SDOH. HEDIS looks at LOINC codes. And so lots of education in the primary care space about what LOINC codes are, how you can get them documented in your EHR, and then how you share that data with all the MCOs. LOINC codes cannot go on a claim. So there's lots and lots of education, as well as potentially technology changes with how a provider documents SDOH in their own system. And then lastly, we're excited to be offering a pilot with Stellar Health. They are a vendor that Passport will be offering to 3 KPCA providers as a pilot in 2024. And it is essentially a provider incentive based on process steps. It gives the provider practice an opportunity to kind of engage the office staff, the non-clinical staff, in their opportunities to impact whether a member closes a gap when we call them to schedule an appointment, when we send them a reminder, when they actually show up for an appointment and get the immunization or whatever particular care gap we're trying to address. It gives them an opportunity to earn an incentive at each one of those steps in the process. So we're really excited to roll that out with some provider partners and see if that, how that impacts compliance rates going forward in the targeted measures. So that's all I have for Passport by Melina.
Thank you, Michelle. So we will transition to United Healthcare. Whitney, I just saw you turn your camera on. Are you going to take this one for your team?
Sure I am. Yeah. Good morning. I'm going to share my screen. Okay. Good morning, everyone. Whitney Allen. I'm the new Quality Director for United Healthcare Community Plan in Kentucky. So recognize there's a lot of overlap, in our HEDIS goals, especially in alignment to the VBP and DMS quality strategy, and then those performance improvement projects that the other MCOs have spoke about. So going to stay very high level, more on our approach overall to our 2024 quality initiative. So happy to follow up with more detail as needed for any of these programs or initiatives. So chronic disease, diabetes, especially children, adolescents, as well visits and immunizations, and then postpartum care in alignment with the VBP are really front of mind for us. So we are taking more of a socio-ecological approach to address these priorities. So really ensuring that we have integrating approaches, so there's no standalones, that they're all kind of working in concert together, and that we're aligned with our pop health and health equity strategy. And then we're addressing those barriers or social drivers of health to really influence those preventive health services and outcomes. So oftentimes to impact the individual health, as you all know, there must be that impact to community and systems. So again, just ensuring all of our approaches are really integrated. So have these broken out really high level. Again, happy to share details on any of these. So revamping our member reward system, those incentives to make sure that we're aligned with the VBP and the quality strategy for next year. Doing just kind of, we call them table stakes, those automated reminders via text, email, mailings on upcoming preventive visits. Really ensuring that we have those coordinated care management programs and some targeted SDOH initiatives. Doing medically tailored meal delivery. We've got a doula pilot. Diapers as a value-added benefit, a peer support program. So really thinking of some of those social drivers of health in conjunction with closing some of these gaps in care out. Also offering some take-home screening kits, like for A1Cs, care tablets, and just overall member education. And then for providers, of course, ramping up our VBCs and provider incentive programs to align with the VBP and quality strategy for next year. We have our PQECs, our provider quality engagement consultants, and our provider relation advocates that are actually boots on the ground, meeting with providers to walk through our PCOR reports and share promising practices and ways for helping to close gaps in care and reporting that we're also able to offer. And then overall provider education. And then from the community standpoint, we are launching some mobile units throughout the state in conjunction with some provider partners to really try to close gaps in care around some of our pediatric measures, the well child visits, immunization. So we're really excited to offer that. Doing some focus groups through community listening sessions, especially in advance of the upcoming new pediatric oral health PIP, to see what potential barriers there are for not being able to get some of those, some of that care according to the PIP. Have some targeted community investments. We are trying out some value-based contracts with CBOs. And then we have a Catalyst program over in Western Kentucky that is more of community focused. It's not just for UHC members, but looking to really focus on people with diabetes and closing out some of those social drivers of health and barriers. So happy to provide any details on any of these programs, do some site visits with our PQECs for the providers, but that is all I have for UHC.
Any questions from the committee for Whitney? All right. WellCare?
Hi, this is Stuart Owen with WellCare, and I'm going to hand it off. I'm going to share and hand it off to Heather Hayhoe with our quality team. Can you all see? We've got a slide, Quality Focus 2024. Can you see that?
Yes.
Okay, thank you. The floor is yours, Heather. Let me see if I know she's on the call.
I apologize. I was
No
on
problem.
changing screens. My apologies. Hi, I'm Heather Hayhoe. Thank you for this time to share our initiative. So for WellCare of Kentucky, we're heavily really focusing on the BBC program and the quality strategies. So getting together as a health plan and collaborating together across the plan. We've developed cross collaboration work groups to support the different HEDIS domains, which are focused on these priority measures along with the other measures that we actively have to support. And we're working on addressing the current interventions we have and looking for gaps and barriers within that to identify how we can improve our members' health outcomes. So assessing them, are they meeting the goal? Are they doing what we need them to do? And then looking at how we can improve them to improve the members' health outcomes and addressing those barriers that we're finding for our members related to the SDOH needs, transportation, food insecurities, the housing, all the different things that are impacting their ability to get the appropriate care that they need. So we're actively developing work plans to work through those improvement activities and related to those targeted measures. We are heavily focused on, again, addressing the data behind it. So looking at where our members are having, what regions where we have the highest prevalence of noncompliance, and really targeting in where we can have the greatest impact. The other thing we're focused on is developing a program from start to finish for our pregnant moms. So making sure that we're addressing them from the very beginning to the theme from the very beginning through pregnancy, delivery, and then the child, having their making sure that they're getting their well child visits, their immunizations on into adolescence. So tying that all together in one program to help support and improve those measures that are really critical related to the VBC. Here are just some of the interventions that we have in place already. So focused on CLIPA visits, working with our providers, collaborating with them with PR and pharmacy, our health coach calls where we're reaching out to our members, scheduling appointments, providing the education with them, letting them know about their value-added services related to member incentives, the different, information that we have related to, for instance, Good Measures is one of our programs we have to help our members with diabetes and obesity and cardiovascular, which we found to be very beneficial. And so they spend a lot of time educating our members on those services and helping to enroll them in those services, and then also making sure that they're getting the appointments they need and working through any barriers they might have. We also have member incentives to encourage that compliance and help support the member offset some of the costs that they have related, to their daily life. And then really looking at how we can implement services to help support the SDOH needs and continue to support our members.
Yeah, and I just noticed as it's been mentioned before, there's a heavy emphasis on child health immunizations and the well child visits. And Dr. Hoagland earlier was talking about the immunizations, and there's clearly a spillover from the COVID vaccine hesitancy into other immunizations which have been declining. Which of course, and I know we've talked about, it's just critical for all of us to try to brainstorm. We've tried different approaches, but to try to collaborate, on how to overcome that, and especially I believe even younger female parents in particular who are very hesitant about their children getting immunized.
Yes, they are. And then the difference, one of the issues too is they're looking at immunizations differently. So, looking at the schedule and wanting to change the schedule, they don't want to have as many vaccinations all at once. So working through those barriers and helping to educate our members and our providers on the importance and continuing to work through those. And then finding ways to continue to make that schedule, how can we address that as quality professionals and working with our providers to still maintain that schedule, the required schedule, but spacing them out to help support the member. So I think there's a lot of challenges we have in place related to immunizations and how we're going to be able to meet those measures. I think they're definitely a critical need, but everyone has their own personal view on immunizations, and so we have to work through that and help them to see the value and hopefully get those immunizations for their kids to protect them.
I agree. It's been pretty interesting post-COVID, just the way that our families that used to get flu now view the flu vaccine even. even a couple, even in 2023, we're already seeing it this season as well, that families who had pre-COVID been pretty amenable to getting the flu vaccine are dead set against it.
Yeah, there's some data that was shared in the immunization. There's another TAC call that I attend where we're doing the immunization survey for the providers, and they shared some data about people who normally would have gotten the flu vaccine are now not going to get it. I think it's like 1 in 4 adults are refusing to get it now, which would mean which would also have an impact on their kids. So if they're not willing to get it, then they're less likely to also get it for their children. So.
All right, thank you very much. Any questions?
Sorry, I was going to say, I'm sorry about Susan Vickers' drama with the transformer blowing, but it results in WellCare not being last for once.
Maybe we need to think about reverse alphabetical order for you guys periodically.
Oh, it'll be a grab bag going forward. We'll mix it up so that it's not always alphabetical in the way that we learned the alphabet.
I'm grateful for the committee's grace in that. Timing is not always perfect. I was queued up and ready to roll and then heard a boom outside my window. So thanks for your patience, and to my colleagues and the other MCOs, always appreciate your teamwork. Could get an email off to Stuart in my phone to say, hey, can you tag team and go first? So thank you all so much. So much as you all have heard from our colleagues in the other MCOs, Aetna's 2024 priorities really are reflective of our DMS 3-year quality strategy. We have specific emphasis this year on achieving a more equitable health outcome for each of our members in our population. Our team gathered recently for a 2024 visioning and strategy session, and really started to hone in on these main areas of focus that you see at the top of your screen. As you know, we are honored to serve our SCI population, who have a plethora of and a very high volume of behavioral health needs and concerns. So that always really kind of trickles into our strategy to ensure that they are receiving the care, as well as the kind of non-HEDIS program related outcomes that we strive to improve that system of care in general. Our member and provider engagement strategies are really hoping to ramp up in the next year to ensure we are optimizing all the administrative support possible for our providers, partnering with you all as we work together to engage those members, specifically those that have been hard to reach. And then, as technology has improved over the last few years, we hope to leverage that in order to meet our members where they are. And then health equity, which we feel is directly impacted and related to health outcomes in our population. So the first area of reach that we really do feel that is possible and most impactful next year is on the left bottom side of your screen. Our analytics tell us that our male, African American and Black members, as well as our Hispanic male members, are those that are most disparate in their health outcomes. They have the most separation from the rest of our population in receiving the health care, both preventative and behavioral health care that they deserve and need. So that is one of our main focus areas for 2024. We are working to, as someone said, listen to the voice of our customer and of our member, identify these populations, meet them and greet them, listen to them through focus groups and community partnerships, to determine what is that barrier in utilizing services. Why is there such a lack of visits to a PCP for Black African American males over the rest of our population, and what can we do to increase those visits on an annual basis? And then also, what can we do to improve the prevention and management of their chronic diseases, specifically diabetes? finally, we do see such a decrease in access of behavioral health for these populations. We know that, as Dr. Hoagland said, you know, BH volume is increasing, those costs are increasing, but we are seeing kind of a disparity in who is using those services. And so we really do want to look in 2024 at follow-up care, medication adherence, medication utilization of our members who are kind of most disparate in that area. We hope to look at overdose prevention. We hope to use some kind of focused targets in certain counties. We see Hopkins County, we see Pulaski County, we see Jefferson County. We see some really kind of spikes in some of these disparities in certain areas that we also hope to focus on. And then finally, our huge focus, as everyone else's, on child and maternal health. How do we get our kiddos and transition age youth into those well visits so that they can learn the importance of and receive those immunizations, so that they can receive their, you know, BMI and exercise and nutrition counseling. And if they're an adolescent on an antipsychotic, you know, how are we making sure that they're getting their metabolic screenings? As are many others, we're looking at and approaching many of you all to realign our value-based contracts to these measures, and both changing the measures and ensuring the targets are fair and equitable for you all, and where we can work together to meet those marks that we're all striving for. We are also increasing our member incentives, as well as other provider administrative and incentives as well. Also, you know, how are we improving those outcomes for our pregnant and newly delivered moms and their babies? We do have some doula assistance coming in 2024 that we've added to our suite of programs. And then our breast cancer screenings. We work with many of our value-based partners on breast cancer screenings to get mobile units and kind of decrease those barriers that we see among these members. And we'll continue to do that in 24. So again, thanks to the committee for your patience with me, and happy to answer questions.
Are there any questions from the committee? All right. Hearing none, we'll transition to other business. Veronica, one question that came up is, could you talk a little bit about the lack of open enrollment this year and about what that process is going to be like?
Absolutely. Thank you for that opportunity. So we are not doing a Medicaid open enrollment this year. I do want to stress there is still a qualified health plan open enrollment. So so folks who have a qualified health plan do have to go through open enrollment, and that just started yesterday. But Medicaid, we decided, because of unwinding and kind of all the changes going on and people going through renewals and maybe being terminated and coming back on, we, like many states in the country, are not doing a Medicaid open enrollment. What that means, open enrollment for Medicaid is just an opportunity for members to change their managed care organization. Medicaid has a continuous open enrollment for eligibility, but we would generally have about a 2-month period where we would send correspondence to a member. We'd send them information about the managed care organizations, including what value-added benefits that they offer, and give members an opportunity within that period of time to make as many changes as they want during that open enrollment period. It's important to also note, though, that outside of open enrollment, members can still change their managed care organization. It's just a little bit more of an onerous process to do that. And we had just been hearing a lot of concerns from members about navigating that process. And so again, just during unwinding, because of unwinding, we decided to do away with it this year. Does not mean we're permanently doing away with open enrollment for Medicaid, but just during the unwinding period. So what that means is during 2024, anytime that a member may want to change their MCO, they will have the capability of making that request directly to the department, as opposed to the current process is to go through the managed care organization. And so that it's kind of more of a for cause reason. But we're going to allow in 2024 a member just to go ahead and make that request directly to Kentucky Medicaid. We have generally during open enrollment, I think the most we've ever seen, the number of unique individuals is about 9,000 out of 1.5 million people. And then during the year, it's also very low. But again, just for unwinding purposes, we decided to do away with it. We are going to be sending a static notice to anyone currently enrolled to make them aware of the fact that during 2024, this is the way that you can request a change at MCO. And then for anyone new coming in, new enrollees in 2024, after their notice of eligibility is sent, they'll get a separate communication just to let them know they can change it at any time during the year. We also will be promoting the fact that MCOs may still change their value-added benefits. So we'll still be promoting the fact that members should go and check what those are and any changes to those, so that they can take advantage of those value-added benefits.
Thank you for that update.
Yeah, absolutely.
Are there additional items to discuss in other business? All right. Hearing none, are there any recommendations from the committee to the MAC? Barry, how do you feel about the rabies situation?
No, I think Veronica and the MCOs can handle that.
Okay.
Right, Veronica?
Yes, sir. Thank you. And I noticed that Justin Derringer put in the chat for the vaccine rates. If you all can send us some specific examples, then we can take it from there. Thank you.
Sheila's getting that.
Hearing no recommendations, we'll move on to setting our next meeting. I don't think that those dates have been set for 2024. Is that correct?
I am currently working on those. You should receive an email. I have your email prepped. I just want to go back and verify on my calendar. I've got every date with 17 of you guys. Sometimes it gets a little wonky, and I'll make sure I don't have an AM instead of a PM and think we're supposed to be meeting at 1 in the morning. So you should be getting those emails from me in the next day or so.
Okay. Thank you very much.
You're welcome.
All right. Having reached the end of our agenda, is there a motion to adjourn?
So moved.
Thank you, Barry. Is there a second?
I'll second this, Dennis.
Thanks, Dennis. All in favor? Aye.
Aye.
Okay. Thank you all very much for your time this morning.
Thank you all.
Thank you.
Everybody have a good day.
Too.